If you are overweight, obese, pre-diabetic, or have type 2 diabetes, this protocol is for you. Only 12.2% of American adults are now metabolically healthy. 86 million adults in the US have pre-diabetes, and 70% of these individuals will eventually develop diabetes. Being overweight or obese is the main factor for progression to diabetes. The best way to reverse diabetes is to not get diabetes in the first place, because your chances of heart disease, cancer, and death are increased even as a pre-diabetic. Our protocol offers real hope and transformational change to patients who would otherwise be consigned to a lifetime of medications, doctor's visits, and suffering. Welcome to ReverseDiabetes.md.
Hi, I'm Dr. Gurpreet Pata. I'm a board-certified anesthesiologist, interventional pain physician, and addiction specialist. Today I'll be talking a little bit about one of our protocols that we utilize to help patients with obesity, prediabetes, and diabetes type 2. Non-alcoholic fatty liver, diabetes type 2 are both considered irreversible. The medical literature would have you believe that these are chronic diseases with no future. That once you're diagnosed with these, you're going to be stuck with medication for the rest of your life. The chances of obesity reversal using standard of care is 1 chance in 167. 80% of the US population is facing prediabetes, and 70% plus of those patients will go on to diabetes. Only 12.2% of the US population is now healthy. We have a method to help patients get appropriate treatment and get reversal of disease. We call it time-restricted nutrition. It's really the amount of time that you spend per day eating compared to the time that you don't eat. It may be even more important than how much you eat. And we're going to go through that in this presentation. Most people eat from the time that they wake up until the time that they go to bed. They eat 3 main meals, they eat multiple snacks, and they often drink soda in between. What this does is it causes tremendous insulin spikes. These insulin spikes are large, they're frequent, and nearly 12 hours of the day, the patient is exposed to elevated insulin levels. Their glucose goes back down to normal because they're spiking insulin. Insulin forces the glucose into the cell. The problem is, insulin itself is a disease process. Hyperinsulinemia causes fat accumulation in the liver, which makes the liver insulin resistant over time, which then eventually leads to metabolic syndrome and eventually leads to diabetes. The real issue with diabetes is not necessarily the glucose. The real issue is the excess of insulin. The real issue with non-alcoholic fatty liver is not that your liver is filled with fat and looks like pate. The real issue is that you're being exposed to extraordinarily high levels of insulin. And those high levels of insulin cause intercalated fat, which deform the liver, deform the cells, and cause liver dysfunction. The way we pick that up is measuring something called GGT, and that's done in another presentation. Constant eating. This pattern of constant eating leads to constant high insulin production, which eventually fatigues the insulin receptors. Keep in mind that insulin is a fat storage hormone, and this elevated insulin level leads to fat storage and fat accumulation and metabolic inflammation, or meta-inflammation. Your body exists only really in 2 states. Either you're being fed state or you're in a fasted state. In the fed state, you're consuming nutrition and your insulin level is high. In the fasted state, you're not consuming nutrition, your insulin level is low, and in the fasted state, you're mobilizing your stored fats. So either you're storing fat, which is fat storage, in the fed state with insulin, or you're dissolving fat, or lysing fat, or burning stored fat, and that's the fasted state. If you eat from the minute you roll out of bed and don't stop till you go to sleep, you spend almost all of your time in the fed state. And the amount of insulin you produce constantly fills the liver with fat, and it's nearly impossible to go back to normal. Over time, we end up gaining weight because we don't allow our body time to return the stored energy back into the system. Time-restricted feeding shortens the time window that a patient eats. It shortens the amount of time that the patient is feeding, or the fed state, and lengthens the fasted state. This reduces the total amount of insulin produced for the day. And remember, insulin is the fat storage hormone. So the less insulin that's globally produced for the day, the less high level of insulin production, the less duration of insulin production, means that the body has less time to store fat and more time to dissolve fat. Time-restricted feeding is considered a type of fasting. It has incredible benefits. You certainly will lose weight. You'll certainly lose body fat. But the key element is that you lower your blood insulin. And when you lower your blood insulin, your blood sugars go down, and you can reverse type 2 diabetes. It improves mental clarity and concentration. It probably assists and reduces Alzheimer's risk. Alzheimer's is considered type 3 diabetes of the brain. It activates a cellular cleansing mechanism called autophagy, and it reduces inflammation. Time-restricted feeding is a type of fasting. It is not starvation. Starvation is involuntary. It's when somebody keeps you from eating and you don't want to not eat. Starvation can be severe. It can lead to death. Starvation is not deliberate. Starvation is not in your control. Time-restricted feeding is deliberate and it's in your control. Time-restricted feeding or fasting is done by somebody who is not underweight. You should have plenty of fat to live off of. And it's interesting to me, people think, well, I'm not necessarily going to do fasting because I'm going to starve to death. And they're 20, 30, 40, 50 pounds overweight. You could probably run 20 to 30 marathons being 20 pounds overweight and never starve. Intermittent fasting done right should not cause suffering. Food is easily available. It's right here, but you choose not to eat it. You can begin your fast at any time of your choosing, and you can end your fast at will. You can start or stop for any reason or no reason at all. Intermittent fasting is any time you're not eating, you're intermittently fasting. For example, you may fast between dinner and breakfast the next day, a period of 12 to 14 hours. And you may fast between dinner and lunch the next day, a fast intermittently of 16 hours. In that sense, intermittent fasting should really be considered a part of everyday life. You should be doing intermittent fasting every single day. Like I said, insulin is the fat storage hormone, and it causes fat accumulation. And when you lack insulin, you get fat dissolution. Fat turns into fuel. We have some facts about being in the fed state. So if you have glucose in your serum, if you have glucose in your bloodstream, and you have insulin, it's quickly shuttled into the cells and turned into fat. Insulin at the same time stops the fat from dissolving, so you get fat storage. But in the fasted state, there's no insulin. In the fasted state, glucose does not go to fat accumulation, and it opens the channel for fat storage to be rapidly converted into energy through a process called lipolysis. And effectively, you can either produce ketones or you can produce triglycerides or glycerol. It dissolves the fat into a usable format and allows the mitochondria, which is the energy generating portion of the cells, to function. Insulin secretion is typically triggered highest by carbohydrate loading, next highest by protein loading, and least by fat. And if you look at blood sugar, insulin mirrors the blood sugar going up. Protein certainly does increase insulin, but not to any significant component. And fat increases insulin the least and also increases blood sugar the least. Things we know that reverse diabetes and obesity. Like I said, people say that none of this stuff is reversible. But we know that there's models that show that it is reversible. For example, bariatric surgery is considered a disease-modifying procedure for diabetes type 2. Gastric band or bypass is effective. But the problem is it carries a significant risk. There are drugs that we can use to stave off the complications of diabetes, but they don't necessarily reverse the disease. Lifestyle changes are key to managing type 2 diabetes, but don't always control the blood glucose level. Time-restricted feeding works. Time-restricted feeding fills the gap in obesity and diabetes care by providing calorie restriction and all of the hormonal benefits of bariatric surgery without the invasive surgery. Time-restricted feeding is defined as a controlled and voluntary abstinence from calorie-containing foods for a period of specified time. It's controlled by the patient. During the fasting period, patients can drink unlimited amounts of low-calorie fluids, water, coffee, tea, and even bone broth. The whole goal is not to have calories and not to have insulin secretion. Sometimes you have to add salt, sometimes you have to add a general multivitamin to make sure that you're getting your adequate micronutrients. The goal at the end of the day is to improve metabolic flexibility. Time-restricted feeding or meal timing strategy reduces the swings of hunger, and it alters the burn pattern for fat and carbohydrates. Under normal circumstances, if you are not fat adapted, you don't have metabolic flexibility. Under normal circumstances, if you continuously eat sugar, you continuously eat food, your pathways for fat adaptation and for burning fat are unused, and unused pathways turn off over time. Metabolic flexibility restores those pathways. It allows the body to easily and simply transition between burning carbohydrates to burning the existing fat. Metabolic flexibility is the ease with which the body transitions between the two different states of fed and fasted without having cravings or hunger pangs. If you have cravings, if you have hunger pangs, you have a tough time transitioning between these two states, and that means that you're metabolically non-flexible. Insulin naturally rises during feeding. As insulin rises, you get fat storage, and as insulin ebbs away, you get fat burning. During feeding, insulin is elevated, which signals the body to store excess. This should give some people pause. And there's an interesting finding that if you take a type 1 diabetic and you put them newly on insulin, they all get fat over a short period of time, because in the presence of insulin, you store fat. In the absence of insulin, which is what type 1 diabetics look like, they're incredibly skinny because they can't store the fat. And that should tell you something. The more insulin you have, whether you produce it yourself or somebody injects it, the fatter you get. And it's the fed state. Most overweight patients live in a constant fed state and rarely in a fasted state. They continually burn glucose rather than fat at the cellular level. They have insulin resistance caused by chronically high insulin levels, which promotes fat storage and suppresses fat mobilization. These patients are overweight, but they feel like they're starving. They're sugar burners. And if they stop eating for even a few hours, they run out of glucose from their last meal and can't transition to the fasted state because they're metabolically inflexible. And so they get acute brain signals of hunger and cravings, and they have to eat right now. They become incredibly hungry and incredibly angry that they're not eating. They may even develop low blood sugar because they're not used to that transition, and they may even feel jittery, and they may have reactive hypoglycemia. This is a huge clue that the patient lacks metabolic flexibility. Metabolic flexibility is determined by your mitochondria, and the mitochondria can burn either glucose or fat for fuel, but it develops a preference for one over the other over time based upon which pathway is being utilized. You have to restore that metabolic flexibility. You have to restore the fat-burning pathway to become fat adapted again, to increase the flexibility. Being fat adapted takes time. It takes patience. Your body has to do a number of things to slowly upregulate or increase your fat-burning pathways. You have to improve the insulin sensitivity. You have to upregulate the fat-burning pathways at a cellular level. You have to redeploy those enzymes. The human body will not spend energy maintaining unused systems. So once you reuse the system, once you reactivate it, it takes time. It's not going to happen in one day. It might take a week or two to re-regulate the systems, to get them back to where they're supposed to be. Don't give up on the first day or the second day or the third day if you have an issue. There's 5 ways to improve fat adaptation. The low carbohydrate diet with high fat improves the body's ability to utilize fat for energy over glucose. Exercise. High intensity exercise depletes glucose and glycogen rapidly, and it forces the body to switch to fat for fuel. Caloric restriction. Eat fewer calories, and the body's forced to dip into the fuel of fat to run itself. Intermittent fasting forces the body to spend more time in a fasted state, giving the body more practice at burning fat. If you really have difficulty, ketone supplementation may be useful. Ketones don't use insulin to get into the cells. They're independent of insulin, and ketones can power the mitochondria. So frequently, we'll use ketones as a supplement for the first week or two to help patients transition into fat burning. This is an incredibly useful tool to lessen the patient's feelings of cravings. It's also incredibly useful in our patients that have Alzheimer's, who have dormant systems in their brain and they're insulin resistant in their brain, and the insulin doesn't work in their brain to get sugar in, but you can bypass that system by supplementing with ketones. Patient engagement is the key. If the patient's not engaged, if the patient doesn't understand why we're doing this, this will fail. Morrison et al. Did studies on this, and they found out that you had to interact with that patient about every 2 weeks or less in order to make a real difference. If you waited and did the typical follow up with me in 3 months, it didn't work. The patient failed miserably. And that probably explains why the standard of care is only 1 in about 167 to 175 patients actually succeed in weight loss using the standard of care, which is eat less, move more. You have to give patients real tools, and you have to reinforce those tools in a way that's understandable and is immediately beneficial. So our protocol can reverse obesity and type 2 diabetes. It can also assist and reverse a non-alcoholic fatty liver disease by resensitizing the insulin receptor and restoring a normal cyclical insulin production, a normal ebb and flow. It's really important that we get rid of that high level of circulating insulin so that we stop constantly storing fat. We want to restore that ebb and flow. We want to restrict the number of hours per day. We start at 8, then we go down to 6, then we go down to 4 for the number of hours per day that a patient is eating. Over time, they'll become fat adapted, they'll become metabolically flexible, and they'll have restored their normal insulin sensitivity, and their time spent with high insulin levels will decrease, and that'll improve their metabolics. It'll reduce their metabolic inflammation. It'll essentially wash the liver out and get rid of the extra fat. Time-restricted feeding is a type of intermittent fasting. Restricting feeding times to a shorter window each day is what we're going to try to do. We go about an hour a week reduction. until we get to between 4 to 6 hours per day. You really have to be careful with medications because blood pressure medications and glycemia medications or sugar medications and even some of the antidepressants can have a significant impact. So this is not something that patients should necessarily do on their own, especially if they're on medications. We want to have the patient eat to satiety, because if they don't eat to satiety, if they don't eat till they're satisfied, they're going to be constantly hungry. And if they're getting a constant hunger signal, they're going to end up overeating, and they're not going to follow this protocol. There's 4 real steps to success. Before you start, you have to talk to your healthcare provider. Second step, stop all sugars. Third step, focus on proteins and healthy fats because that's what's going to make you satiated. And fourth step, start slow. Realize you're going to fail. Realize you're going to get back up and you're going to do it all over again. Before you start, talk to your healthcare provider. You want to get healthcare advice that's specific, and you're going to have close monitoring. It's important to understand your medical history. You have to understand your medications. You have to understand that high insulin causes vessel wall thickness and less flexibility. And as you get away from vessel wall thickness and improve your vessel flexibility, your blood pressure drops. And so if you're on a blood pressure medicine, you're going to have to reduce that medication. If you're on a medication that reduces blood sugar and you're taking less sugar in, you're going to have to reduce that medication. You're going to have to make adjustments to insulin. So there's a whole host of medications that we have to make adjustments for as we progress. And this process is called deprescribing. We want you to closely coordinate this with your healthcare provider. We want you to stop all your sugars, including the artificial sweeteners. Sugars and processed carbs are not satiating. We want to get rid of those sugars and artificial sugars that sweeten beverages. We want to get rid of the things that are in your food. We want to stop all sources of vegetable oil and replace with healthy natural oil. We're going to get rid of the omega-6s and increase the omega-3s. The omega-6s are linoleic acid, heavily oxidized, and incredibly toxic to the liver. Once you replace with real fat, your food actually tastes better. We want to stop all processed foods. Processed foods have acellular carbohydrates in them. These acellular carbohydrates have incredibly high glycemic index and cause you to eat every 2 to 3 hours because the insulin level spikes and then it drops. The glucose level spikes and then it drops. And they're designed in such a way that they're shelf stable, but they make you eat every 2 to 3 hours. We want you to focus on proteins and healthy fats. We want to get meals rich in protein. This could be beef, fish, chicken, eggs, lamb, seafood. There's even vegetarian meals that are extraordinarily healthy and rich in protein. We typically use pea protein for people that are more vegetarian oriented. And if they'll tolerate yogurt or cheese, those are incredibly nutritious and filling as well. We want to use low sugar vegetables, olives, peppers, and cucumbers. We want to avoid things like fruits. The fruits that we have now are sugar bombs, and we don't want patients to artificially increase their insulin by taking a sugar bomb. This approach will allow a patient to get more fat adapted more quickly and easier to improve their outcome. We want to start slow. The metabolic inflammation or the meta-inflammation didn't happen in a day. It's not going to go away in a day. We started in an 8-hour feeding window and we slowly decrease it about an hour a week until we get down to where we need to be. Things to think about. Before you start this process of intermittent feeding, we want you to have changed your diet. We want to change over to a healthy diet of satiating foods, healthy fats, healthy proteins, no processed food. We want to change the diet first and then start the time restriction. This should not be a miserable experience. If you're having a miserable experience, something has been overlooked. You're doing something wrong. There's something that you're consuming that's not satiating, or is an artificial sugar or an acellular carbohydrate, or you're getting linoleic acid somewhere, or your hormone system is off. We don't use time-restricted feeding as an excuse to eat junk food when you are eating. We want to continue to avoid processed foods. When you start time-restricted feeding, you may have to supplement with salt, you may have to supplement with ketones, you may have to supplement with multivitamins at first. These are all things that we talk about. You don't really have to worry about losing muscle mass from the lack of protein. As long as you eat adequate protein in the meals that you're eating, you don't have to supplement with shakes or smoothies or anything of that nature. Low carbohydrate, high fat diet pairs perfectly with intermittent fasting and improves fat adaptation rapidly. Exercise, high intensity, I prefer weightlifting, is the best option, and exercising regularly. It'll deplete the liver of glycogen, it'll deplete the liver of fat, and allow metabolic flexibility to return and insulin sensitivity. Drink plenty of water, especially while you're fasting. And remember, you may have to supplement with a little bit of salt and multivitamins at first. The easiest way is to skip your morning meal. Give your body more time to burn fat. Breakfast is probably the worst meal of the day. It artificially increases your calorie consumption by 350 calories a day plus, and it makes you hungry for the rest of the day. And naturally, your hunger is lowest in the morning, so it's the easiest meal to skip. You just break your fast later in the day. Warnings. This is not for everyone. Time-restricted feeding should not be used for people who are underweight, for people who have eating disorders, if they're pregnant, if they're breastfeeding, if they're children under the age of 18. This is not what we recommend. We don't recommend time-restricted feeding without consultation with a physician or a healthcare provider. This is not something that, if you're on medications, you should be doing on your own. Medications have to be adjusted. You can actually get toxic. You can actually get hypoglycemia. You can actually get low blood pressure. You can actually have psychiatric issues if we don't adjust the medications properly. If you need more help, we have a lot more to offer. If you have any questions, please contact me.
This has been Dr. Pata with ReverseDiabetes.md. Remember, the information discussed should not be considered specific medical advice and does not constitute a physician-patient relationship. This field is extremely complex and requires a direct physician and patient interaction. Each patient is medically unique and the exact protocol will need to be tailored. If you need further assistance, call our office at 314-481-5000 or send us an email to info@reversediabetes.md.